Good afternoon. My name is Paul Cleary. I'm the Dean of the Yale School of Public Health. People are still coming in, but I thought I would start by welcoming you. I'm incredibly excited to welcome you to this second conference of the Centennial Award of the C.E.A. Winslow Medal of the Yale School of Public Health to Dr. Fauci. On behalf of the school, I'd like to extend our immense gratitude to the faculty, staff, students, and alumni representatives that comprise both the Winslow Medal Selection Committee and the Centennial Planning Committee, both chaired by our Deputy Dean, Dr. Brian Lederer, for making this historic occasion possible. The Winslow Medal is given in honor of the founder of our school, and many would say the founder of modern public health in the United States. It is awarded to world-renowned innovators with distinguished careers and outstanding achievement in public health leadership, scholarship, and contributions to society. Past recipients include Sir Richard Dahl, Dr. William Fagey, Sir Ian Chalmers, and Sir Michael Marmot. The final Centennial Medal will be awarded in 2 weeks to Dr. Judith Roden. Nominations for the Centennial Medal were sought from the entire Yale School of Public Health community, from the deans of schools of public health across the country, as well as from leaders in the National Institutes of Health, the Centers for Disease Control and Prevention, and the World Health Organization. Before introducing Dr. Fauci, permit me to say a few words about C.E.A. Winslow. He was born in 1877. He was educated at the Massachusetts Institute of Technology in 1898 through 1899, respectively. And he taught at the University of Chicago, the City College of New York, and Yale, and served as editor of the Journal of Bacteriology and the American Journal of Public Health, and was president of the American Public Health Association. At Yale, Winslow was chairman of the university's first Department of Public Health at its inception in 1915. In the course of his 30-year tenure, he brought Yale, the department, and himself considerable international and national distinction and acclaim. The world's changed a lot in the last 100 years, but science has changed too. During that time, hygiene developed into preventive medicine, bacteriology evolved to include parasitology and virology, classic epidemiology evolved to include clinical epidemiology, control of communicable diseases became chronic disease control, and public health increasingly focused on social determinants of illness and health. Winslow developed public health into a premier educational program that graduated not only students with master's and doctoral degrees in public health, but also medical students imbued with, as he would say, a preventive spirit. Yale was the first academic institution in the U.S. to recognize the importance of public health by establishing a degree-granting program in this field. And in 1946, the program was one of the first 8 groups of schools to be nationally accredited as a school of public health. Many of the advances made in public health nationally and internationally during the last half of the last century were made by those who followed Winslow at Yale, such as John Rodenpaul, Dorothy Horseman, Jim Niederman, John Thompson, Max Thier, and Jordi Casals. The evolution of the Yale School of Public Health has continued in more recent decades, building on the intellectual vision of Winslow, as evidenced not only by the research achievements of our faculty, but also by our many graduates who have gone on to become exceptional public health leaders. 100 years after the inception of our school, and with infectious diseases and access to care and treatment continuing to be formidable global health challenges, it is fitting to award the C.E.A. Winslow Medal to Dr. Fauci, rated by Fortune magazine as one of the world's 50 greatest leaders of our time. As the people in this audience well know, Dr. Fauci is the director of the NIAID at the National Institutes of Health. Since his appointment as director in 1984, Dr. Fauci has overseen an extensive research portfolio devoted to preventing, diagnosing, and treating infectious and immune-mediated diseases. Dr. Fauci is also chief of the NIAID Laboratory of Immunoregulation, where he has made seminal contributions to the understanding of how HIV destroys the body defenses leading to its susceptibility to deadly infections. Further, he has been instrumental in developing highly effective strategies for the therapy of persons living with HIV/AIDS, as well as for a vaccine to prevent HIV infection. He continues to devote much of his research time to identifying the nature of the immunopathogenic mechanism of HIV infection and the scope of the body's immune response to HIV. Dr. Fauci serves as one of the key advisors to the White House and Department of Health and Human Services on global AIDS issues and on initiatives to bolster medical and public health preparedness against emerging infectious diseases threats such as pandemic influenza. He was one of the principal architects of the President's PEPFAR program, which has already been responsible for saving millions of lives throughout the developing world. Dr. Fauci is a member of the U.S. National Academy of Sciences and is the recipient of numerous prestigious awards for his scientific and global health accomplishments, including the National Medal of Science, the Mary Woodward Lasker Award for Public Service, and the Presidential Medal of Freedom. He has been awarded 42 honorary doctoral degrees and is the author, co-author, or editor, those of you in this audience who think you've been productive, of more than 1,270 scientific publications, including several major textbooks. In sum, there are few people in the field of public health who have had such a profound impact on global health and infectious diseases. In the spirit of Winslow, this work has evolved extensive communities of professionals and lay persons which directly promote Winslow's goal of preventing disease and promoting health. It is thus an extraordinary honor and privilege for me to present the Centennial C.E.A. Winslow Medal to our esteemed guest, Dr. Fauci. Please welcome Dr. Fauci to receive this medal.
Thank you, Paul. Thank you very much. Thank
I
you.
was told not to drop this on. I've been told not to drop this on the floor.
Great, thank you.
Thank you, Paul. Thank you, Paul, for that very kind introduction. It's really a wonderful pleasure to be here with you this afternoon, and an extraordinary honor to receive the Winslow Medal from Yale School of Public Health. The subject that I'm going to talk to you about today, if one looks at the first slide, may seem, when one thinks of the epidemiology of this extraordinary pandemic, as to maybe be a bit over the top, that we're going to be able to end this pandemic. But what I hope to develop with you over the period of this discussion is the scientific basis why not only do I think that this is achievable, and I'll get back to it in a bit, but I think it's almost inevitable that it will happen if we do a few things. And what it's going to be an interdigitation between the discovery of the science that gives us a good basis to do this, and importantly, the implementation of that science. So let me get on with it, and I'll hope that you'll understand the threads that I'm going to be putting together for you on this. So first, let's look at the nature of the problem. So I pressed down and it didn't move, so let's try this. Okay. Uh-oh, I did something wrong. So I usually press the arrow that says go, and it goes, but it's not going. So where's that wonderful young lady who I gave my wallet to? Right. I don't trust you anymore. Okay, so this is the arrow that says go, right?
You should be able to do it right here.
Okay.
Try that.
Okay. There you go. Thank you. You can keep the wallet. Okay, so the numbers are very daunting, and that's what I was saying when I was alluding just a moment ago why this seems like such a lofty goal. If you look at the numbers, we've gotten so used to the numbers that we almost take them for granted now. both internationally and domestically. So there have been 76 million people infected with HIV, 34 million deaths, 37 million people living with HIV, and the number that's as disturbing as the history of this is what's actually going on right now, the ongoing pandemic with 1.2 million deaths and 2 million new HIV infections. When I make rounds on my patients and when I talk in my lab meetings, it's very difficult because most of the fellows were actually not born at a time then when there was no HIV/AIDS. So they didn't know a world without AIDS. So they take for granted something that we need to keep emphasizing, that in the short list, like a handful of the major scourges on human civilization, this ranks in the top few. The bubonic plague, pandemic flu of 1918, the smallpox outbreaks, etc. It's not only globally. In the United States, where again there's complacency, there's 1.2 million people living with HIV. Interestingly, and I'm going to get back to this because this is huge, 13% of people who are infected in the United States don't know that they're infected. I'll get back to why that's so important. There have been over 650,000 deaths and 50,000 new infections over the past 2 decades. The two parts about this bullet that are disturbing is the 50,000 number and the 2 decades number. Because if you were with a couple of people I see in the audience that were around then, in the beginning of the epidemic, the number of cases per year were doing this, and it peaked like around 120, 140,000 in a year. Then it came down to 50. But the problem is it stayed at 50 for almost 2 decades now, and we're going to get back to that. The demography has changed. It was in the beginning, in the early 80s, a middle-class, young, white, gay man with some percentage of injection drug users. Now it's predominantly gay men, mostly African-American. We'll get back to that in a second. And they're youths. The infections now, 25% of them, more, are in, I think, at least when I look at myself in the mirror, children between the ages of 13 and 24. But that's what the demography is. So a more graphic representation of this, if you look at the pie chart in the last recorded numbers in the United States and look at the United States, Puerto Rico, and other areas, 65% among men who have sex with men, more than 50% of which are African American, 17% among heterosexual females, 8% among heterosexual males, and the 4% for injection drug users was a bigger slice of the pie in the 80s. We did something really simple, despite the lack of federal support for that, was needle and syringe exchange, which completely turned around. The reason I tell you that now in the beginning of the lecture, because that was the implementation of something that was really simple. And now we're going to have to start implementing things that are a little bit more complicated. So if you look at what's happened in the field, the extraordinary amount of investment that has been made in basic and clinical biomedical research on HIV, it is true to say that an amazing amount has been accomplished, breathtaking in many respects when you think of what's happened. In the areas on the slide, none more impressive or important than the arena of treatment. And I have to give examples before the Congress about the relationship between basic research and applied research and an endpoint in health. Just look at the treatment of HIV infection from the very beginning. So this is a picture of, believe it or not, me in 1981 in January taking care of one of my HIV-infected individuals. I show that picture. It makes me smile a little because I had all black hair then, but it also makes me sad a bit because I still can't get over the feeling that I had for many years, from 1981 into the 90s, where almost all of my patients died. Well, the reason is they came in with advanced HIV infection because we didn't know it was HIV until they were sick enough to get into the hospital. So when this picture was taken, the median survival of my patients were anywhere between 8 months and a year and a half. It got a little better as we got better at treating opportunistic infections. But until we developed the drug, you could look a patient in the eye when they asked you to honestly tell them what lies ahead, and it was really rather bleak. So what happened? What started was an extraordinary assault in the area of science, of looking at fundamental basic issues. And that's what I meant when I said how we can justify all of the money that we put into HIV and the money that we have to keep putting into HIV. So this is a schematic diagram that I'm sure is very familiar to members of the audience of the HIV replication cycle, with all the things we understand about the issue of binding, fusion, entry, reverse transcription, integration, then budding with protease enzyme involved. And what this has led to, as we all know, was the first drug. AZT was actually a cancer drug, which shows you about the interdigitation between disciplines. That was a reverse transcriptase inhibitor. But most of what's happened since then has been targeted drug development. Now, there was targeted antiviral drug development before HIV with some of the herpes viruses and others. But targeted drug development has really come into its own in the arena of HIV, such that if you look at all the great advances that we see now with hepatitis C, which is actually curable, is based fundamentally on the advances that were made in targeted drug development for HIV. So what was the result of that? The result of it over years, starting off with a single drug, then two drugs, and then the transforming year of 1996, when we first had the triple combinations, which were with a protease inhibitor and nucleoside reverse transcriptase inhibitors, which has now, for the most part, been replaced by integrase inhibitors and other types of targets. We now have about 30 of these, which when used in combination, you already know, have completely transformed the lives of HIV-infected individuals. So in the same room where I showed you that picture of me on a patient, I made rounds, what's today, Friday, on Wednesday, with a person that came in similar. I'm not making this up for the effect of the lecture. When the person came in completely undiagnosed for the first time, I looked him in the eye. It was a 21-year-old Hispanic individual that when we put him on drug, we could tell him if he takes his drug that he will likely live an additional 50 years until he's into his mid-70s. So let's take a look at this now. When you look at the application of antiretroviral therapy, there are two aspects of it. One is obvious, treatment. But I'm going to get to in a few minutes another aspect of antiretroviral therapy, which has emerged over the years as almost as important when you think of the broad scope of the epidemic. So here's the chart that I was referring to you. So if a young person came in early on with a few drugs, they had a dismal life expectancy. Now it's about 71 years if they come in at age 20. And you could do all the modeling about why this is the case. This is not only now in the developed world, because with PEPFAR, the Global Fund, the Gates Foundation, the Clinton Foundation, right now, what we have is 15 million people receiving antiretroviral therapy. When I went down to, when President Bush sent me to Africa in 1982 to start the development of the beginnings of the PEPFAR program, there were less than 50,000 people in low and middle income countries who were receiving ART. Now there are 15 million, which means that over a period of about 14 years, almost 8 million lives have been saved. And again, I tell this audience that knows that, this is the greatest argument you can have for investment in biomedical research that leads to a result. Because we often get asked, when I get before the Congress, what have you done for us lately? We're putting so much money into it. What have you done? This is what the biomedical research community has done. And if you look at the numbers, they speak. More than 40% decrease in deaths in the last UNAIDS report. So that's treatment. What about prevention? Well, when we started off in the early 80s, there were very low-tech, even non-medically related things. A tire armamentarium has emerged. First, there was the use of condom, behavioral modification, then clean syringes and needles. And then we started to integrate medical interventions with prevention. such as medical male circumcision, prevention of mother-to-child transmission, treatment as prevention, which we'll get into in a moment, and a variety of others. With all of these, and I'll get back to some aspects of them in a moment, again, the numbers have dramatically changed, with a decrease of more than 35% of new infections since 2000. An amazing amount of accomplishment, but much more to be done. And that gets back to the theme of my first slide, why I think we can actually turn around the trajectory of the epidemic if we do it correctly. So let's start with some fundamental principles. The foundation for all HIV treatment and prevention efforts is testing for HIV. Now, that seems really rather simple, but it's very difficult to implement that. The CDC has now recommended that everyone gets tested at least once, and people at high risk can get tested as often as every 3 to 6 months, depending upon the risk category. So let's take a look at what happens when you test somebody. Things have changed over the last several years. So one of two things happen. You either test positive or you test negative. So let's look at what happens if you test positive. There's a phenomenon called the care continuum. And the care continuum means from the time you get infected to the time you are on therapy, your viral load is below detectable level. And we know from studies that I'll get into in a moment, that means it is extremely unlikely that you're going to infect anybody else. That's the care continuum. So how are we doing with the care continuum? I mentioned that 13% of the people who are infected in the United States don't know that they're infected. I'm going to get back to that number in a second because that's very important. Here's where we drop off really badly. Of the 1.2 million people infected, only 39% of them are receiving medical care. 36% have been prescribed an antiretroviral drug, and dismally, 30% of them are virally suppressed, which means they're saving their own lives and they're not infecting anybody else. Now, that's in the United States as a whole. There are some areas that are doing much better than that. Hopkins is doing much better. The Ryan White group is doing much better. San Francisco is doing much better. But as a country, it's 30%. So if I were playing 20 questions, what country in the world is doing much better than we are? Rwanda. Rwanda is doing much better than we are because if you look at the number of people infected, the number of people on therapy, they have about 70+% of their people are virally suppressed. So we have a ways to go. Now, this is the slide that blows me away. If you ask a question, who is infecting whom in the United States? Of the 13% of people who don't know they're infected, they're infecting 30% of the 50,000 people who are getting infected each year. Now, talk about failings of medical care. If you look at the people who are diagnosed but not in care, they are infecting 61% of the people who are getting infected, which means if you just diagnose somebody with HIV and put them in care, that you would be decreasing by 91% the number of infections in this country. So I could actually stop the lecture right now and say, if we just did that, you would have the curve do this. But we're not doing it. So let's take a look at some of the things that we can do. This issue of diagnosed but not in care is a real phenomenon. It's not just a statistic. A common occurrence that I experience when I make rounds on my ward at the NIH is someone, usually a Hispanic or an African American, who went into a clinic 2 or 3 years ago because of a broken leg or got shot somewhere in Washington, D.C., got an HIV test, and then was lost to care. And then comes in now with a CD4 count of 4 and multiple opportunistic infections. That is not an uncommon situation in this country. So some of you may have heard of the 90-90-90 target. So that's a UNAIDS target now, which says that if you take 90% of the people who are infected and diagnose them, and take 90% of those and put them on treatment, and take 90% of those and virally suppress them, you will encompass about 73% of the people who will be virally suppressed. If you do a mathematical model of that, the trajectory of the epidemic does that. So although this is a goal, if we accomplish it, we can do exactly what my first slide said. So let's see how the United States is doing on 90-90-90. The goal is to get there by 2020. So the blue is 2020, the red is where we are now. We're not doing that bad with diagnosis, because they said only 13% of individuals are not diagnosed, even though they comprise 30% of the new infections. But take a look at the on-treatment, how badly we are behind the goal, and look at the virally suppressed. So clearly, we have a long way to go. So I've had to, over the past year or so, make some arguments. One, when I was working with the people in New York State, when Governor Cuomo was putting together his blueprint for ending the AIDS epidemic in New York State, and now I'm working with some of my colleagues in the White House to try and put together a program to make some model cities. I always get asked, as everybody does, what is the scientific basis for investing so much money to do this? Because when you're dealing with government funds, they always need to know the scientific basis of doing it rather than just throwing money at it. So let's look at the scientific basis. Turn the clock back 10 years. You can actually turn it back more than that. But in the beginning, when we were treating people with multiple drugs, sometimes two, and then we got the triple combination, the big question was, if you start somebody early, is the cumulative toxicities of the drug worse than having somebody be viremic continually? There was a real argument about that. So we did a study about 10 years ago called the SMART study. And the question was, should you treat somebody only when their CD4 count drops below a certain level, and then when it comes back up, stop therapy, so that at the end of a period of time, there'll be some people who are on therapy for a longer period of time and others who will be on therapy for a shorter period of time? And the answer was unequivocal. The things that we thought the drug was doing with toxicity was due to chronic viremia and immune activation. So that's the first thing. The second major study was the treatment as prevention study, the now iconic HPTN 052. Typical study that was randomized study controlled, discordant couples, start someone early on therapy, the infected person, wait to start the infected person, and compare what the rate of infection from the infected partner to the uninfected partner. Again, unequivocal. If you start right away, 96% decrease in infections that are transmitted. That's referred to as, I know many in the audience know that, but for those who don't, it's the treatment as prevention approach. Then the people who had trouble with that said, now wait a minute. If you start somebody with a high CD4 count who feels well, it's good for the public health because you're preventing infection, but is it really good for the person? So we did another study called the START study, which asked just that question. Treat people who are over 500, no matter what their count is, or wait till it drops to 350. And guess what happened? The people who were treated early unequivocally did better than the people that were waiting, which tells us something very important. Right now, if you look at the individual benefit and the public health benefit, there's absolutely no excuse whatsoever not to treat every person who's HIV infected with an antiretroviral drug. Period. Case closed. The reason I get animated about that is I've spent years arguing about that. And now we have all the scientific data we need to do that. And in fact, on the basis of our studies, the WHO a few weeks ago came out with the recommendation that all people living with HIV should be offered antiretrovirals in addition to all of the other things we give to them. Now, the real question is, how are we going to get the resources to have them to be able to implement that? And that's, again, the implementation gap. Let's move quickly on to prevention continuum, because years ago, when we were a little bit lax, we would say if you're infected, we'll put you on therapy. If your test is negative, you're really great, thank you, goodbye, have a nice day. That's not what we do anymore, because the people who are at risk, who are negative, need to get into a continuum that's exactly the same as if they were infected. And that continuum is counseling, stratifying which risk you're in, and depending upon your risk. Are you a gay man? Are you an injection drug user? Are you in a discordant relationship? And to provide them with that toolbox of prevention, which was that circle ring that I showed you. You want to retain them in service, and you want to have them adhere to prevention the same way as you want someone who's infected to adhere to treatment. So, what else has evolved over the last several years? And that is the use of therapy as prevention. In the early years of the AIDS epidemic, there was a reluctance, because that's the way the field of infectious disease was to treat someone who wasn't infected to prevent them either getting an opportunistic infection or getting HIV. That has all changed right now, because there are at least 4 areas where treating an uninfected person, in this case preventing mother-to-child transmission by treating the infected mother so the baby doesn't get infected, pre-exposure prophylaxis, post-exposure, and I already told you about treatment as prevention. Let's examine just a couple of those, because I don't have time for all of them. Pre-exposure prophylaxis. That means giving an antiretroviral drug to someone who is at risk for infection. I could show you 2 slides full of studies which indicate that it is 95% effective if you take the drug. If you don't take the drug, it's not effective. There was a nice study from Kaiser Permanente in San Francisco which just asked that question. Let's take people who are at risk and give them Truvada. Let's take people who are at risk and wait a year. Again, there were no infections in the people who got Truvada. Treatment as prevention works. In Baltimore, you put people on therapy, the incidence decreases. In Rwanda, you put people on therapy, it decreases the incidence. So I'm going to spend the next period of time, I'll stay on time, talking to you about cure and vaccine, the 2 last challenges. Is my water there? Can somebody get me some water? Thank you. Putting all my energy into this, I'm getting dehydrated. All right. Okay, so I already told you when you put somebody on therapy, you can load the level of virus, they'll do well. You increase their expectancy by 50 years. I'm going to talk to you a little bit about the cure. There are 2 things that people are talking about the cure. One is to eradicate the virus. Now, that's very difficult with HIV because HIV integrates itself into the genome. So you can suppress the virus, do very well, but not be cured in the classical sense if your definition of cure is to have prolonged, if not indefinite, remission without the need of antiretroviral therapy. Now, there are 2 ways that you can do that. One is really difficult, and that is to eradicate the virus. We've tried for years to do things like flush out the virus by activating the cells while they're receiving antiretroviral in the hope that you would activate all of the latently infected cells and be left with no cells infected. It doesn't work that way because despite a considerable amount of effort thus far, we've not been able to do that. Then there are more draconian approaches, such as immunotoxic therapy directed at the reservoir, stem cell transplants. You heard about the Berlin patient. I'm really glad that the Berlin patient is alive and doing okay, but the Berlin patient developed a leukemia that required chemotherapy, 2 allogeneic transplants with someone who has a genetic defect that the virus can infect the cells and is currently on immunosuppressive therapy. That's not practical for 37 million people who are HIV infected. It's a very interesting proof of concept, but that's not something you're going to do. Gene therapy, gene editing, very exciting. I'm going to have to hold judgment about where we're going. One of the ways that's probably more doable, but we're still in the process of doing experiments. We're doing experiments in my own lab and in several other labs, is to try and control the viral rebound, discontinuing drug, but not necessarily trying to eradicate the virus. And the ways you do that is you rely on natural HIV-specific immunity. We've tried that. I've tried personally discontinuing therapy in a large number of people, and with very few exceptions, everybody rebounds. So somehow or other, we don't like, and I'll get back to that with vaccines. The other thing that's really a hot topic that you keep your eye on is the passive transfer of HIV-specific antibodies, sort of like the old days of passive immunotherapy we used to give, as well as therapeutic vaccines, which would then hopefully allow you to discontinue therapy with sustained control of viremia. The message I want to leave with this group, and I didn't go into any great details about the science of cure, is that when you're talking about cure, it really needs to be simple, it needs to be safe, and it needs to be scalable. Because in my mind, curing 9 people that make the front page of the New York Times when there are 37 million people who are infected is kind of interesting for nature and science and whatever, but it's not interesting from the standpoint of the epidemic and the pandemic itself. I'll be happy to answer questions about that when I finish. All right, vaccine. So now this is exciting. It's exciting because it's a challenge, but it's exciting because it's really unique in immunology and the interdigitation between a microbe and the immune system. And let me explain what I mean by that. Now, the talk I gave you about we already have the tools to do what we need to do if we just implement them. If you listen carefully, you could say then, gee, why do we really need a vaccine? Well, I gave a version of this lecture, and all of my vaccine colleagues started emailing me. What are you doing? You're trying to put us out of business. So I had to write an article in the New England Journal of Medicine. Ending AIDS is an HIV vaccine necessary. So I submit to you, yes. If you're a vaccinologist, don't worry about it. And the reason is I think you're going to have a vaccine for a quicker getting to the goalpost, but importantly, a durable end to the epidemic. Because what we've seen with so many infectious diseases, malaria is the typical prototype of that. You get in a region, you get down almost to where you want to be, and then people stop putting an effort into it and it bounces back. That's one of the important reasons why you need a vaccine. So let me tell you about vaccines, because it's really an interesting historical story. If you look at the history of vaccinology, I want to divide it into 2 approaches, what I call the empirical or inductive approach, and the theoretical or deductive approach. Let me explain. Empirical means you test a candidate just empirically, typical killed vaccine, live attenuated vaccine, until you get protection, and then you try to improve upon that to get an effective vaccine. The theoretical approach is more cautious, more scientific, more erudite. That means let's figure out what we're trying to induce first, and then fashion the vaccine to induce that. Now, if you look at the empiric or inductive approach, essentially every vaccine that we've ever successfully developed has been through the empiric approach. So let me explain that vaccinologists have a paradigm, and that is that mimic natural infection. So whether it's smallpox, measles, polio, you get morbidity and mortality, but ultimately the body clears the virus of the infection. You're left with immunity that in most cases is lifelong. So nature has already done the proof of concept for you. What you need to do is mimic natural infection. And that's what we've done with all of the vaccines. We've even given a whole vaccine, killed or an attenuated. Unfortunately, we don't have that grace, as it were, with HIV because natural immunity is not very good. So This is a complicated slide that is the historical menu of what we've done from the early approaches in 1987, in which we did trials of envelope-induced non-neutralizing antibody, didn't get protection, were completely puzzled. I was one of those. In fact, the first vaccine trial that was done with an FDA-approved product was done in the NIH Clinical Center by my colleague Cliff Lane, in which we just gave an envelope to someone and said, hey, we're going to wind up getting an antibody and that'll be it. Yeah, we got an antibody, but the antibody was only good against lab-adapted strains and didn't do anything to primary isolates. Then we switched over to T-cell vaccines to try and suppress the set point of the virus. Make a long story short, we were quite unsuccessful. But there was one success, and that one success was an empirical approach in which a prime boost of a vaccine was done in Thailand, now referred to as RV144, which had 31% efficacy. Not ready for prime time, but at least you had something to work on. So now that fits right into the empiric approach. You now have a proof of concept, try to improve on it, and that's exactly what's going on. And the interesting surprise, the one thing that's great about science, you all know this, you're scientists, is that it's full of surprises. So when we got the 31% efficacy, we thought we'd find a clear correlate of immunity that's neutralizing antibody or cytolytic T cells. Everybody was looking at cytolytic T cells. When we found out it was an antibody that was an IgG against a region of the envelope that we never paid any attention to because it was a variable region, so we didn't think it meant anything. That's the first surprise. The second surprise is that it wasn't neutralizing. It was an ADCC antibody, antibody-dependent cellular cytotoxicity. There was no CD8 cytolytic cells, and interestingly, if you made an IgA antibody against it, you blocked the response. So everything about our paradigm was wrong. It wasn't neutralizing, there were no CTLs, and it was against a region that we never would have guessed. So what are we doing now? We're trying to improve upon it, increase the strength, the breadth, and the durability with multiple different types of approaches, more boosts, modified vectors, or adjuvants. So now we get to the stuff that's really exciting, but I have to hold judgment as to whether or not we're even going to be possible to be successful. And that is the theoretical approach. And that means, so I'll go slow in this, follow me, because it really is very interesting. That is that we know that the gold standard of vaccines is to induce a neutralizing antibody that covers all strains. That's referred to as a broadly neutralizing antibody. Okay, what's the problem with HIV? Is that broadly neutralizing antibodies are only induced in about 20% of HIV-infected individuals. And by the time they induce it, their virus is not sensitive to it. Bad news, number one. Number two, it usually takes them 2 years of continual viremia to induce a broadly neutralizing antibody. Most of them have a high degree of somatic mutation. For those of you not familiar with that, that means that you've got to stimulate in and out of the germinal center multiple times before you get the antibody. That's not practical for a vaccine. And the other one is they have a very interesting trait of autoreactivity. So with that as a background, the field decided, let's do it in a theoretical way and try to track this down. So this is a blow-up of the HIV. This is the HIV virion, and this is the trimer, or the triple component of the envelope protein, that by any virus, usually, if you make an antibody that's neutralizing against that, you're home free. You got a good vaccine. Okay, so these squigglies are antibodies that are monoclonal antibodies, and we always try to confuse people by giving it strange names like VRC01 and 10E8. For those of you who work in the laboratory, that's the 10th tray, the E row, 8 down. Hello. So these are antibodies that have been developed, that have been cloned from people who are HIV infected, who have, they're part of that 20%, developed neutralizing antibodies. So what does that tell us? The thing is that it binds to a certain part, and if you get rid of the antibodies, these are called epitopes, which are neutralizing epitopes, which means that if the antibody binds to this, then you want to make a response against this epitope. So the critical challenge that we have right now is how do you get these neutralizing epitopes to turn them into an immunogen to induce the broadly neutralizing antibody? That seems like pretty simple. Just go do it. Not really. So what happens? We find out that two important critical factors in the induction of antibody. One is the stability of the envelope trimer, and the other one is engaging the B cell lineage. So I'll simplify it and make it very clear that even those who don't work in this area will understand it. What do we mean by the stability of the HIV envelope? Okay, let me show you some characteristics of the envelope. It's naturally unstable. It isn't a protein that stays this way. It moves around and flips around. It has conformational changes. Number two, the envelope changes upon binding to CD4, and it exposes an immunodominant part of the epitope. By immunodominant means it sucks up all the immune response, and the immune system makes a response preferentially against one region versus another. The problem is that antibodies to V3 have limited neutralization activity. Stable trimeric envelopes preferentially bind neutralizing antibody, so we come to the conclusion that you want a stable envelope, and this could serve as the preferred immunogen. So we now know that. So what do I mean by instability? Let me march through it with you. Let's go back to this envelope with this epitope here. If I superimpose upon that the structural biological squigglies that you usually see when people show the structural biological conformation, this is what it looks like. So I'm going to pull out the schematic and leave you with this. So this is the pre-fusion HIV envelope. By unstable, we mean that when the envelope binds to the CD4 molecule, it starts doing funny things. One of the things it does is it flips out this protein, this V3 loop. The problem with that, as I showed on the other slide, is that antibodies that are now going to be preferentially made against this while ignoring all these others have very limited neutralizing activity, which finally, after 20 years, explains why when we were given the envelope, we were getting antibodies that weren't neutralizing anything because the immune system was being directed against doing something that was irrelevant to protection. So this is the stable envelope. When the envelope is stable, neutralizing antibodies all bind to these in a very, very clear way, which means that this is the preferred immunogen for vaccination. So now we know, after many years, that the preferred immunogen is the stable envelope. A couple of really good studies from John Moore at Cornell, John Mascola in my group, and Peter Kwong show that you can actually get, in a crystal structure, a conformationally fixed and stable envelope. So you would think, okay, now we have the envelope, it's going to be easy. How do you engage the proper sequential engagement of the B cell lineage? What do we mean by that? Bart Haynes, 2 years ago, did an interesting experiment that was an experiment of nature. He happened to get hold of someone who was being followed very carefully in a prevention study who got infected. And the first antibody that was made is referred to as the unmutated ancestor antibody. What it is non-neutralizing. And what happened was that as the antibody was made, the virus mutated to escape the antibody. Another antibody was made, the virus mutated to escape that antibody. And they kept on doing this for 2 years until finally you got a broadly neutralizing antibody. So the thought occurs now is that perhaps if you really want to mimic natural infection. HIV is doing something that no other virus is doing. Why don't we, and Michelle Nutzenzweig from New York articulated this in a review article, why don't we have a vaccine that iteratively stimulates the immune system till it matures to the next stage, and then another immunogen to mature, so that you could, over a period of months, hopefully, trigger the development of broadly neutralizing antibody. The one problem with that is that the epitopes here are not recognized by any germline B cells that are in your B cell lineage. So you have to figure out what the proper immunogen is to start the process off. And that's not going to be easy. It sounds very difficult and confusing. It's certainly difficult. And it is starting to be done in recent papers that just came out over the summer, in which they've done knock-in mice and non-human primates, where they were able to engage the B cell lineage to start to do this. Again, it's not going to be very easy. And in fact, it's probably one of the most, I would think, profound challenges in vaccinology that we have ever faced in history. I've never seen anything like this, where you're trying to get the immune system to do something it doesn't really want to do for natural infection. So before I close, let me just a couple of more comments about, while we were doing all of this work on broadly neutralizing antibodies and identifying it and cloning it, there's now a bunch of studies that are saying, well, if you can't make the body do the neutralizing antibody, can you actually passively infuse it? And there are a number of studies now that for prevention and treatment are using passive transfer of antibodies, either alone or by just inserting the genes of the antibody into a vector and then just inserting that into the host. So it's interesting because it's, we used to do this 60 years ago when you were doing passive transfer for things like diphtheria and things like that. But we're starting to think about that now. Finally, the T-cell approaches, obviously, there are a number of things that are going on. T-cells are very important to provide help to B cells, but also, particularly some experiments that were done by Lou Picker and his colleagues, indicate that under the right circumstances, CD8-positive T-cells could be induced to kill HIV-infected cells. So with regard to a vaccine, let's go back to what I told you, that the RV144, the TIDE trial, it was 31% effective. That's no good. It's not going to make prime time. The measles vaccine, as I use as a paradigm, is 98% effective, which means that if you take a shot when you're 11 to 12 months, when you're supposed to take it, and then you come back at 4 to 6 years, which is your booster, it's about 98% effective, which is the reason why I got so upset when mothers were not wanting to vaccinate their children against measles. It's one of the most effective. It is the most effective vaccine. We're not going to get a 98% effective HIV vaccine. I just can't see how that's going to happen. But somewhere in between, whether that's 50, 55, 60%, together with non-vaccine prevention, I think that's going to be the durable nail in the coffin of HIV. I think we're going to put some nails in even without the vaccine, but the durable nail is going to be. So with treatment and the comprehensive HIV prevention, this is the end point and this is the goal. So this is my last slide, and I want to just make just a comment or two about that. 5 years ago, my colleague and I, Greg Focus, wrote a paper at a time when I just started thinking about this, and I entitled the paper, Controlling and Ultimately Ending the AIDS Pandemic, a Feasible Goal. Now, as my first slide, it's not only feasible, in my mind, it's unquestionably achievable. Now, over the next 5 years, I hope to be able to write a paper that I think we're going to be able to do. It may take 10 years, but hopefully in 5 years, that we've actually turned the tide on that if we implement the things that we already have. And I've spoken to several of you today about the issue of implementation science. But if you implement what we already have with a little extra dose of a vaccine and possibly some cure work, that the title of this is going to be Controlling and Ultimately Ending the HIV Pandemic, an Achieved Goal. Thank you. Yeah. Greg.
So Tony, you talked about how important implementation science is, but I think with the PhD students, you also turned to us and said it's not the role of the NIH to do this kind of research. If it's not your job, whose job is it? Who's going to fund it? It's not going to come from CDC. They don't have the resources or the expertise. It's not going to come from PEPFAR. Who's going to do it here? Who's going to fund implementation science and do all the things you said that need to be done with the tools we have today?
Okay, so I do think that it is the role of the NIH to be able to participate in funding implementation research. I really do think that PEPFAR and the Global Fund and the Gates Foundation and others should be investing more. In fact, PEPFAR, in fairness to them, has a program in which they've divided several millions of dollars, 15 million in the first year, to us, to me, to CDC, and to USAID to do implementation research. The difficulty, and it's, as you know probably better than anybody, the idea of doing implementation research from a fundamental basic and clinical research organization, there's a lot of pushback on that from the Congress and others who fund it. Well, somebody else should be doing that. And that's the reason why when Eric Goosby was the director of PEPFAR, we came to an agreement that he said, I have some money, and implementation is important for the success of the PEPFAR program. Will you guys partner with us? And that's how we started. It was me and Tom Frieden and Raj Shah. So you're absolutely right. We need to do it. Oh, there's got to be more questions than that. Jerry.
So, first of all, thank you. I don't know if anyone who could summarize 30-some-odd years of HIV so brilliantly and succinctly, and thank you. So thinking forward, and this is an implementation question as well, we probably have the resources here to enable implementation, but the full force of the epidemic has passed, and with lots of residual here that we have to deal with, of course, but in areas like South Africa or where I work in the rest of the world, implementation remains really so dependent upon the strength of the health system and the will and the political will of the leadership. So so this is, and I guess my question would be how you and others, leaders, really see your role and have and will continue to see a role in terms of maintaining the view that this is a global epidemic and not one that just affects the U.S. With great concerns that we all have that there'll be diminished interest in the global epidemic into the future as things actually settle down and increasingly improve here. Yeah, I don't know if that was a clear question.
It wasn't, but that's
We're worried about the rest of the world as we actually probably can achieve the goal here. What's going to happen where actually the resources are not just the research and the implementation resources, but the basic resources of the infrastructure in the countries that we serve?
It's a very relevant, Jerry, but a complicated question with a complicated answer. But let me try and be as simple as I possibly can. The relationship between implementation and a healthcare system is absolutely essential. And the better we get with the full implementation of the Affordable Care Act, the full implementation of Ryan White, I think we'll do much better in this country to do that. What I'm trying to do, and I'm hopefully we'll be able to do it in the next 15 months of the administration, and hopefully the next administration would be interested in it also, is to show some demonstrations in some particular cities that if you actually apply in a very intense way with HIV, I mean, it should apply to every disease, that you could actually bring the epidemic down to essentially nothing. San Francisco is doing a fantastic job in that. We started it in Washington, D.C., and brought it from the worst place in the country to now doing very well. I actually think if you're looking at the political climate of what makes people move and do things, they like to see results. So if you could take some representative cities like Washington, San Francisco, Oakland, Atlanta, and Baltimore, which is the 5 that we're concentrating, not that the others aren't equally as worthy, but we've made connections with that and prove that you can do that. I think that there will be government resources to do just what you're saying people are forgetting about, not forgetting about, but are not paying much attention to. Globally is a different story. It's very interesting that we have to continue to fight against that. The way things are right now with funding, things are so tight and there's so much conflict between ideologies in Washington that we're held hostage to that, even though most people agree that this is a good thing to do. Again, Rwanda is a great example of what can be done. And I think if we get Rwanda to really go down, the other countries might look around and say, hey, maybe we should be making more of an investment in healthcare systems. The idea of investment in healthcare systems is emerging now as the real global problem. I mean, people are starting to get it. There would not have been an Ebola catastrophe in West Africa if they had even the slightest semblance of a healthcare system. It wouldn't have happened. It just wouldn't have happened. But it exploded just because of that. I think people are starting to get that. Yeah.
This is a little bit on the other end of the spectrum. We've learned a lot about chronic viral infection from HIV. And increasingly, we're recognizing that chronic viral infections are driving a number of chronic diseases. What are your thoughts about what we can learn about the study of chronic viral infections more generally in terms of controlling chronic disease from our experience with HIV?
Good question. There's a little bit of a disconnect, not in your question, but in the concepts, because what we are trying to do, struggling with, is identifying an unknown virus that might be triggering a chronic, what appears to be non-infectious disease.
Well, we know about several other.
Right. No, let me finish. There's two aspects of it. There's that if you're saying that this looks like it's some sort of an immunological response to an infectious disease, chronic fatigue syndrome or what have you. And then there's the associations of, HPV, hepatitis C, hepatitis B, cytomegalovirus, EB virus. I think the more we study this, the more we're going to realize that there are connections there. And that's the reason why we're working on trying to develop an EBV vaccine. People say, what do you need an EBV vaccine? I think the EBV vaccine is going to be a big breakthrough if we have the EBV vaccine. The difficulty with making it, like I said, the disconnect, there's not in your question, was HIV is really a different story. HIV is a clear, highly replicated virus that takes a long time under most circumstances because it acts indirectly in killing the host as opposed to, for the most part, directly. That's what I meant by the disconnect.
Dr. Fauci, I have a question over here. Hi.
Oh, hi.
It's a real honor to have you here. And I actually had two questions. One is molecular, and then one is more based in public health. But I was curious about your comment about the tailored immunogen approach to the development of a vaccine. And you had mentioned also very briefly that certain broadly neutralizing antibodies have unusual traits, such as autoreactivity. And then as you closed out that component of your talk, you said basically the idea of iterative immunogens was to try to get the body to do something that it doesn't want to do.
Right.
So I was wondering if you could comment whether there's a connection there. Is there some sort of autoreactive component or something like that, please?
Yeah, okay. So it's a very good question. Not all of the antibodies have autoreactive capabilities. The antibodies against the membrane proximal external domain, the EMPER, are very strongly weighted towards autoreactivity. Bart Haynes has done a bunch of studies to show that to a greater or lesser extent, several of the antibodies have autoreactivity. And the reason he thinks is one of the reasons why we don't make it is because of tolerance mechanisms. And that if you actually, it isn't that you're going to induce an autoimmune response if you induce a vaccine response with an antigen, is that if it's being controlled by tolerance mechanism, can you break tolerance to the specific antigen without triggering autoimmunity? So you're absolutely right. That's one of the things that breaking tolerance may be one of the things we need to do in addition to finding the right germline B cell to engage with.
Okay, terrific, thank you. And then my other question was somewhat to what's already been addressed here, but in terms of your full-throated and very impressive comments about the United States not being where Rwanda is in terms of having viral suppression among only 30% of people living with HIV and AIDS. And then you mentioned learning from San Francisco and learning from some of the urban areas. I wondered if you, as a molecular scientist, but also someone with this public health perspective, could comment specifically on some of the issues, like, for example, in the rural southern U.S., where we have a serious kind of stable problem and there's 50,000 cases per year. How can we bridge these issues with all the molecular work and also this very powerful need not only to deal with urban areas, but also nationwide? Can we learn from Rwanda? Maybe you have some specific, how do we bridge these two fields? And how do we learn in the United States from other countries that are doing better on this?
So I'm not so sure that you need to bridge the field of molecular confirmation of an immunogen, which is going on in Alabama. I think you just need to do both. I would reframe your question, if you'd allow me to do, is that should we be putting as much effort into both? In other words, finding all the molecular nuances of things if you don't address the problem that we're having in the southern part of the country where we're having, ongoing outbreaks of HIV is not appropriate. So that's how I would answer it, that we absolutely need to do both. The situation in the southern part of the United States is a real big issue because it's a combination of so many different things, of poor healthcare systems, minority stigma, poverty, all kinds of sociological things that go into the fact that where there wasn't an epidemic like that years ago, now that's, if you look at the map of the United States and you do a heat map on it, that part of the country lights up, as you well know from your question. I just think we need to do both.
Okay. Thank you.
Yeah?
Thank you, Dr. Fauci, for your talk. I'll take that. Sorry. Thank you so much for your talk. So recently we've seen there's been quite a lot of publicity about the high prices of drugs that have come to market. And I think it's wonderful that NIAID is investing so much in research for a vaccine. And I was wondering if there's a plan to regulate the price of the vaccine should it come to market to ensure that access is not limited to those who can afford it.
Yeah, it's going to be very different with regard to the price in a vaccine. In fact, I don't want to, how do I say it so I don't get quoted badly? I think with regard to a vaccine, I think it's going to be likely close to free. I mean, I don't think there's going to be a vaccine for HIV that's going to be $300 a vaccine. I think that what's going to happen is that because of the amount of money that will be saved by preventing a single infection, that's going to get bought up by governments. It's going to get bought up by Gavi. It's going to get bought up by a whole bunch of groups that I worry so much less about the price of a vaccine as to whether we're going to get a vaccine. Don't worry about that. It's not going to happen. First of all, the vaccines are being developed in academia, and when we license it out now to these companies, there's clearly going to be with the provision that it's going to be at a price that is minuscule. I mean, really minuscule. Yeah, but see, I could give you a simple answer that's not true. But let me give you the right answer that's complicated. Years ago, we had something when we had the Bayh-Dole Act about Peter knows this better than anybody, God help us. Peter Hutt, formerly FDA, my colleague from many years ago. We had this thing called the reasonable price clause, that if you license out a product that was made by government investment to a company, that they would have to charge a reasonable price. The only thing is, 35 congressional hearings later, we could never figure out what a reasonable price was. To some people, a reasonable price means something that a poor country can afford. A reasonable price to some companies means after I pay for all of the research that failed over the last 30 years, and that's how you get an $80,000 drug. So you're asking how we do it? I don't even think it's going to be a problem because the vaccine is going to be made with a very heavy input from the federal government and companies that we contract with under the agreement that you will never test a vaccine in a country in which the vaccine would not be readily available to them at an affordable price. That's a business decision, and it's an ethical decision. So there's no way that you're going to do a trial like we're doing in South Africa and then get a vaccine that costs $400 a shot. That's it. I mean, that's a contract. You can't do that. No, I mean, I don't even need luck. It's going to happen. Trust me. It's different than drugs. Drugs are a different story. Drugs are a different story. Because there's no doubt that the governments, for example, the government of South Africa, if the companies that we're partnering with to manufacture a particular protein decide they want to charge a lot, we'll just get the protein and make it ourselves and break the patent in a microsecond. That would be it. Right.
You started out your talk this afternoon by talking a little bit about the change in the demographics or population that's infected in the United States. Can you say a little bit more about that in terms of whether that's... Is it not on? Can you say a little something more about that in terms of the population that's infected today? Is it purely have to do, we've talked a little bit about access to health care and things like that, or are there other biological reasons why it might have shifted? And then I actually have a follow-on question, which has nothing to do with that, but I'll ask it now.
Let me answer that first.
Okay.
So if you look at the demography of new infections, it's about 65% men who have sex with men. Of that group, among men, if you look at males, 55% of those are in African Americans. So African Americans are 12 to 13% of the population, and they comprise 55% of all new infections and a higher percentage of the men who have sex with men. And that has to do with a lot of things. That has to do with a combination of access to care, a much greater stigma among African American men who have sex with men than white men who have sex with men. Just in the community, in the church, in everything. It's a very different situation. I mean, it's tough to generalize, but in general, it's a very different situation. If you look at the new infections among women in the United States, 65% of them are among African American women. And it's an interesting combination of sociology and epidemiology, because if you look at the sexual habits of heterosexually infected African American women, their sexual activity and habits is no different than the white population. So there's this misconception that they're having more sex and more sexual partners. They're not. It's a question of essentially being in the wrong place at the wrong time. Take Washington, D.C., before we got involved in putting a full court press. If you look at it, the prevalence of infection in the city was like 3.7%. Among young African American men, the prevalence was 5.8% in Washington, D.C., which is worse than about 17 African countries. So if you happen to be a young African American woman who more likely would be having sex with a young African American man, the chances of your coming into contact with an infected person is infinitely greater than if your cohort of sexual partners has a prevalence of 0.1. And that's pure numbers. So it's a sociology, it's wrong place at the wrong time, lack of access to health care, and a variety of other things. That's what I meant by being complicated.
Can I just follow up? What percentage is from prison populations in terms of the incidents that we have in the prison populations and then going out into the community?
You know, I don't have the correct number for that, but it's substantial in people who are infected in prisons. But the issue with what happens in prisons is that in the most prison systems today, if you get infected, you get treated. What happens is when they get out of prison, they go off medical care, their viral load goes up, they infect people, and then they wind up getting sick. But the exact percentage of that, I could find that out for you. I don't have that.
So is there one final question? Gentleman in the back, maybe?
Yeah.
Okay. As someone who is a leader, who wears many different hats of leadership, who has led for such a long time, what pearls of wisdom do you have for young people that seek to be leaders in the next generation of healthcare?
Seek to be leaders. Okay. Well, leadership is a big category. So the first thing that I tell people, young people who ask me about, advice about career, leadership is, in my mind, very heavily weighted towards leadership by example, as opposed to leadership by position. So my advice is, if you really feel that it's in you to be a leader, then you have to start doing things that are leadership things. In other words, do things that might not be the commonly accepted thing to do. Sometimes when you're doing things that ultimately get you to be a leader, you don't even know that you're heading towards leadership. You might be heading towards criticism. Seriously. I mean, I'm looking at Greg in the front row. When I did something years and years ago about feeling that it was very, very important to get the activist community very much involved in the design, the implementation of clinical trials, the discussion of the regulatory process. At the time, I was severely criticized by my scientific colleagues. They thought I was nuts to doing that because the activists were so provocative and confrontational, but I still did that. So back in 1988, I was criticized by the scientific community who told me that I was not fit to be the leader of the Institute because I was partnering with the activists. 25 years later, I'm the leader for having done that. So what you need to do is to just, by example, but also don't be afraid to do things that are not particularly popular, and do things that you feel passionately about. I think the best leaders are the people who are passionate about what it is that they're doing, because people sense your passion, and then you all of a sudden become a leader for them. So when you feel passionate about something, go for it.
What a fabulous way to end a talk. Thank you for a tour de force, as Jerry said, of 30 years of research and a vision of the future, and more importantly, for all you have done over your career to improve the health of populations domestically and abroad. So thank you so much. And Dr. There'll be a reception on both levels of Harkness, and we're going to give Dr. Fauci an opportunity to drink some water, but he'll be open to conversation. So join us in a reception outside.